Okay, so I think we'll make a start because we have quite a lot to cover today. I wanted to welcome everyone to the second webinar in our webinar series of the North American Society for Interventional Thyroidology. For those of you who attended our first session, we covered a lot of the basic topics in thyroid ablation, and today we're going to move on and talk about some slightly more complex techniques, including ablation of isthmus nodules, complex nodules, including ethanol ablation, multinodular goiters, and vascular ablation. So the North American Society of Interventional Thyroidology was founded really earlier this year and is a great group, multidisciplinary group of people from surgery, endocrinology, radiology, and we really invite you to be members. Membership is free. And at the end, we'll pop up our website that if you have any inquiries or would like to join, please get in contact with us. I'll hand over to Dr. Patel to introduce our panelists and speakers for today, and then we'll get going.
Excellent. Well, thank you very much, and thank you everybody for joining us today. I think we have three fantastic panelists joining us. Our first speaker, Dr. Stefano Spiezia, is joining us from Italy, where it is early morning, I believe. So we are really happy to have him join us. Dr. Spiezia is the head of the Division of Endocrine and Ultrasound Guided Surgery at the C Hospital in Naples, and the director of the Regional Reference Center for Thyroid Surgery in Campania, Italy. He is the adjunct professor of minimally invasive percutaneous thyroid treatments at the University of Turin, and he graduated from the Federico II University of Naples in general and emergency surgery, and completed a master in endocrine surgery at the Vanvitelli University in Naples. His clinical practice is basically dedicated to patients with benign and malignant endocrine pathologies, including minimally invasive surgery, laparoscopic surgery, robotic assisted surgery of thyroid, parathyroid, and adrenal glands. He's one of the pioneers in Europe of thermal ablation of thyroid nodules and has basically been doing this since 2007, publishing his experience. It is a true pleasure to have him join us here all the way from Italy. Dr. Spiezia, I'd like you to go ahead and if you want to start your presentation, that would be awesome.
Thank you, Kepal. Can I start with my presentation? So now, let me congratulate with all of you for the perfect organization of this meeting, this online meeting. And good evening to everybody, even if at this time is night, it's midnight in this moment in Italy. So it's very late, but it's a very great pleasure for me to participate and it's part of this wonderful team. So thank you a lot for inviting me to participate in this very interesting event that allow us to share our experiences and achieve various objectives, mainly informing the colleagues, but above all the patients about the real possibilities that these new procedures have in the treatment of thyroid nodules. The surgical indications are often forced and patients are very frightened and concerned about the consequences of surgery under general anesthesia for possible complications and also for the presence of a scar in the neck. Another goal, I think, is to clarify the real indications to the treatment, offering a variety of options that are tailor-made on the patient and on the lump itself. Finally, clarify that even this procedure, if they are not done in expert hands, can create big problems that can be overcome if there is a great experience and an in-depth learning curve behind them. I'll present two cases that try to answer these objectives and which are open for discussion. There are two recent cases, so I don't have a prolonged follow-up, but the purpose of this webinar is to give you information on the technique rather than on the monitoring of the nodules. So I am ready to share the screen. And I start with the case number one. Okay, do you see? Everyone see?
Yes, we see.
Thank you. So this is the isthmic nodule that you asked me to present before all. And is the case of a young female, 32 years old, with a 4.8 milliliter single isthmic nodule. She has a BMI of 21, so normal weight, normal thyroid hormones, normal antibodies, and she performed one fine needle aspiration biopsy that was type 2 according to Bethesda classification. In this case, we performed only one FNAC, only one fine needle aspiration biopsies, because the US pattern of the nodule was at a very low grade of risk for malignancies. So according to our guideline from the ETA, from Italian guideline, we performed just one fine needle aspiration cytology before proceeding with the RFA. The nodule is a main nodule on the isthmus with some satellite small nodules beneath. This is the this is the appearance of the young lady before the treatment. You see here the large nodule in the neck that she tries to cover with long hair, but this was unsuccessful to completely solve the problem. So she decided to solve the problem without having surgery, with a scar in the neck, and asked me to perform a radiofrequency ablation. This is a transcutaneous laryngeal ultrasound that we perform before and after the procedure to check the vocal cord motility. That you see here is normal. This is the vascular pattern before ablation. You see here a regular peri and intranodular vascularization. This is an assessment with an high-tech detection software for vascularization of thyroid nodules, where we can see all the micro angio pattern of this nodule. This is an image with power Doppler examination of the vascular signal, and we apply the vascular technique for radiofrequency thermal ablation. That means that we start identifying the main artery, the main afferent artery to the nodule that usually is in the paraisthmic aspect of the nodule. Here you see, here you see the vascular pattern at power Doppler and the vascular signal at pulsed wave Doppler. So we identify before all the signal of the main afferent vessel to the nodule. We start with lidocaine anesthesia that is performed with 10 milliliter of lidocaine plus 2-3 milliliter of sodium bicarbonate and preparing to 20 milliliter with the saline solution. So total amount of solution to inject is 20 milliliter with bicarbonate to reduce pain during the injection of lidocaine. We inject the anesthetic under ultrasonographic guidance in a virtual plane that is beneath between the deep fascia of the strap muscle and the anterior capsula of the thyroid gland. Here you see the main afferent artery ablation. We introduced the RFA needle toward the target that we identified before by power Doppler examination. We start with 20-30 watt to ablate the artery till we have this hyperechogenic image of the complete ablation, and we check it by power Doppler examination that demonstrates the absence of vascular signal after the ablation. Then we produce, because the nodule is very superficial, after that we treat the most deeper part of the nodule, we proceed to treat the superficial part of the nodule, but before to proceed, we inject, we produce hydrodissection with cold dextrose 5% in order to create a fluid space, a cold fluid space between the skin and the muscle and the nodule that we are treating. You see here the hydrodissection, and there we go on till the completion of the radiofrequency ablation of the nodule. In this case, we used a 5mm needle that works very fast at 30 watts. So we go on till the completion of the radiofrequency thermal ablation. And this is the image at the power Doppler examination at the end of the procedure. You see there is the typical image with hyperechoic foci in the nodule, inside and on the periphery of the nodule, without any signal, vascular signal inside. This is the image that was detected with the iCheck software of this US machine. There is an absence of vascular signal at the end of the vascular RFA. We performed the RFA with a total amount of 6,745 joule in 6 minutes and 39 seconds at 30 watts as a high level of energy that was delivered during the procedure. This is the transcutaneous laryngeal examination after the procedure. And this is the follow-up at 2 months. As I told you before, this is a very recent case that I show you. So I have only this follow-up. And you can see here that the nodule shrank from 4.8 milliliter to 2.16 milliliter in only 2 months. So this is more than 50%, I think about 55% of shrinking of the nodule. The nodule is completely hypoechoic, homogeneous with well-defined borders, and at power Doppler examination, there is absence of vascular signal at the periphery and in the internal part of the nodule. The nodule is completely avoided with the high-tech detection software for vascular signal. It's completely devoid of vascularity inside when compared with the image before the vascular RFA. And this is the image of the young lady before and this one after the procedure. Thank you for your attention. So I have finished my first presentation and okay. I close my...
Yes, and we might just pause very briefly and just maybe just go over a couple of the things that you brought up, because I think this is a very important case. I think oftentimes the perception is that an isthmus nodule will be easier to ablate than a lobe nodule because it's closer, it's easier to get to. But actually, there are technical issues that you nicely sort of covered with isthmus nodules. I was interested personally, do you try and develop a plane between the trachea and the nodule? you may have mentioned that and I just missed it, but posteriorly, and I would be interested to hear Dr. Park, Dr. Abraham's views on that too. Do you try to develop a buffer zone with dextrose between the trachea and the posterior aspect of the nodule?
Yes, as you can, I'm sure you have noticed during my presentation, when I treat the deeper part of the nodule, yes, we can perform hydrodissection on the deeper part of the nodule, but in this case, the nodule was also very mobilized during the procedure. So I moved the compressing with the probe on the nodule. I was able to move the nodule on the side, on the right side. So I was able to have a distance from the trachea, moving the nodule. So I didn't require any hydrodissection. That could be a factor of difficulty, or could develop some problems for the patient for major compression of the trachea, because you create a fluid space that is not compressible between the nodule and the trachea. In this way, when the nodule is mobilized during the procedure, you can avoid this moving the nodule on the right or the left side, as you can do. And in this case, you can perform easily without the deep hydrodissection. But for the superficial plane, this is impossible. So I have shown to you, in this case, you need to create a space, a fluid space, we call the strokes, between the skin, the step muscles, and the node. It's very easy to perform, because if you are skilled to perform the anesthesia, because anesthesia is an hydrodissection with anesthetic, you can perform the same with dextrose anyway, and you create a space, and so you can ablate the superficial part of the nodule. And you see at the end of the presentation that the nodule is completely devoid of any vascular signal. So the ablation was very, very complete for this case. With hydrodissection, you are sure to avoid complication on the skin, because the burning of the skin is very bad for patient, because you don't produce a scar, but you produce another problem on the neck that's very, very visible for the patient.
Absolutely. Dr. Park, do you have any comments there as well on that, and also on needle entry angle for isthmus nodules as opposed to deeper lobe nodules?
Yeah, I had several cases of the ischemic nodule. One of the thing is it's hard to have a transischemic, and then your needle, should go a little bit far away from the midline, and then it's really, as Dr. Spiezia mentioned, it's very mobile, and then you try to push it to move back and forth. I think he really did a great mention on that. We can intentionally push the nodule in one ipsilateral side, or from the opposite side of needle axis, you can just hold it, and then you can just control the mobile. So I usually do not use D5 or normal cell injection between nodule and then trachea. And then I like to try more close to the surface rather than close to the trachea. And then, usually the side effect or the symptom is usually patient cough, coughing and some symptoms, but it's only a few cases, hard to say, but Dr. Spiezia, he did a great job. Yeah, I think, yeah.
Thank you so much.
We have one or two questions from the group here. So can you please comment on D5W versus lidocaine when you hydrodissect, one versus the other, or a combination of both of them? What are your thoughts on this, Dr. Spiezia, Dr. Abraham, Dr. Park?
I think 5% dextrose disperses much quicker than lidocaine. So sometimes you'll have to continuously inject. But certainly one thing that shouldn't be used is saline for hydrodissection. That's an important observation. The question I had was, 20 cc of lidocaine plus 10 cc of dextrose, that's a large volume to inject in the neck. And I don't know how your patient tolerated it. Maybe you injected it in stages. I'm keen to hear about that.
Okay, I can reply to your question. It's a good question. But I told you before that I prepare a syringe with 20 milliliter of total amount, but in this case, I don't use all the volume.
Okay.
Probably in this case, used 7-8 milliliter of complete solution with lidocaine plus sodium bicarbonate and saline solution. And of dextrose, I didn't use a continuous injection, but I create only one injection to create this fluid space because the needle I use, that is a 0.5 centimeters, very quick. So I don't need so much time to perform the radiofrequency ablation for the need of a continuous injection of dextrose.
The other point you mentioned.
So the total amount is less than 20 milliliter anyway.
The other thing, you put up the patient's BMI, which was 21. We do have patients with BMI of 21, but that's not usually what we find in our practice. Dissection is perhaps less important when the BMI is higher because there is innate space that is available for safety in our patients. So the need for hydrodissection is far less, at least in my humble observation. I'm keen to hear about our other panelists. I'm not as vigorous as hydrodissecting, except in the very thin necks.
Yes, yes.
For hydrodissection, I think 3 hydrodissection, I think we can think about. The first time, the lidocaine around the thyroid capsule, mainly to transfer cervical, nerve, numbing. The second thing is kind of a continuous or kind of maintenance or compensatory the fluid, like a chill D5 or normal saline, normal saline, no more likely. And then third one is where there's a nerve damage, to cool down the already generated heat, we can do rescue, hydrodissection. So for the first hydrodissection, yeah, I think we can minimize the amount of lidocaine. Whatever it's a BMI base or body weight base, it'd be great. There's no need to use a lot of lidocaine unnecessary. And I maybe that is the right way or appropriate way.
Thank you
All right.
very much. Sorry, there was just one question about lidocaine on the trachea, how important. I think if you are trying to develop that plane between trachea and nodule, 5% dextrose is much better than lidocaine because you do want not to numb that cough response and prevent the patient being able to give you an indication as to when heat may be being transmitted to the airway.
All right, let's move on to our next case.
Okay. No, this is the first case. Okay. Is visible my presentation?
Yes.
Okay. This is the second case. This is an autonomous functioning thyroid nodule in a young lady, 40 years old. This is a 12 milliliter right lobe hot single nodule. The patient was treated, was medicated with metimazole 5 milligram 1 tab per day. at the moment of the radiofrequency thermal ablation, the TSH was still suppressed with the free hormones at the high level of the normal range. And we applied the vascular RFA technique. You see here the image with the large bump in the neck, in the right side of the neck. And this is the image of the CT scan with the Auh nodule in the right lobe with all the tissue, the extra nodular tissue, not kept in at the CT scan, completely suppressed. This is the image of the nodule in the right lobe. This is a slightly hypoechoic nodule with not so well-defined margins, with the macro calcification inside, with some areas that appears like spongiform areas inside the nodule. The volume is 11.87 milliliter. This is the vascularity of the nodule with power Doppler examination and with high-tech detection software. You see here very typical vascular pattern of the autonomous functioning thyroid nodules with a venous, dominant venous inside the nodule, and this is the image in the sagittal plane, and an afferent, main afferent artery at the nodule that in this case was very superficial. You see that this artery is that we identified with the pulse wave Doppler and power Doppler was very superficial and beneath the capsule of the thyroid gland. So this was a problem during the procedure, as I show you later. We start with lidocaine anesthesia. We prepare also in this case the syringe with 20 milliliter total amount of 20 milliliter of solution with the lidocaine and sodium bicarbonate and the saline solution. We introduce under ultrasonographic guidance the needle that is a 21 gauge Chiba needle between the space, the virtual space, in the virtual space between the deep fascia of the muscle, the submuscle, and the capsule of the thyroid. You see here the vessel, the artery that is very, very superficial. And we start before performing the radiofrequency ablation of the nodule, we start introducing the needle very close to the artery and ablating the trunk of the artery. And you see that after the ablation, we have absence of signal inside the target we identified before. But immediately after this procedure of the vascular RFA, there was a bleeding from the arterial trunk, producing a large hematoma fed by the proximal arteria, quickly developing, so a large hematoma in the neck between the submuscle and the capsule of the thyroid gland. And you see here that I was able to demonstrate an arterial fistula from the truncated arteria and the space between the muscle and the thyroid gland. So I tried to identify the source of the bleeding and to ablate it until the complete absence of flow in the space that we identified where before we checked the arterial fistula. And you see that and we continued until the completion of the RFA, and you see here that there is no more vascular signal and flow towards the space, the hematoma that was created after the bleeding. So this maneuver was fortunate and successful because we were able to identify before it was too late for this technique to solve the problem. So we didn't need to stop the procedure after we only apply a compression on the neck and an ice bag and check the patient every 20 minutes until she was delivered from the clinic. You see here at the end of the procedure, the nodule was completely devoid of vascular signal inside the nodule that was treated. We applied the vascular RFA with the 1 centimeter exposed tip RF medical with a total amount of 46,692 joule as total amount of delivered energy for 16 minutes and 29 seconds. That 60 watts of energy we used during the procedure. This is the 1 month follow-up. You see before and after 1 month. So the bulge in the neck completely disappeared. The TSH completely recovered. And this is very important because the endocrinological aspect of the treatment was after RFA to discontinue the medication with the methimazole after 5 days. So the patient discontinued completely the medication. It was without methimazole, and at 1 month follow-up, the TSH completely recovered. We don't have, obviously, we don't have the image of the scan, of the CT scan that we usually perform at 6 or 12 months after the procedure. The free hormones were normal. As I told you before, we applied the vascular technique. This is the image of the nodule at 1 month follow-up. The nodule is completely solid and hypoechoic with well-defined margins. The volume was 4.6 milliliter after 1 month. So we have a shrinking of about 60% from the basal volume of the nodule. It's very peculiar, very characteristic to see here that this is the image at power Doppler examination of the arterial trunk, the main afferent artery, that was completely truncated here. And you see here a fibrotic lesion all around the arterial trunk to demonstrate the complete necrosis of the arteria. So thank you, I have finished. Thank you for your attention. And I close my connection.
So, Stefano, that was a fantastic case. So I can tell you that I've been in that situation with the vessel anteriorly and have gotten into bleeding. And I was not as successful as you are in being able to stop the bleeding. So I just had a lot of pressure for a while.
I told you it was a fortunate solution. But there was a moment that I think that what I have to do now, I have to open the neck of this lady because I saw that the hematoma was enlarging, but I need a quick solution to solve the problem. Compression was not fast to solve the problem. Ice bag the same. So I tried to do this to complete the ablation, burning the fistula, the arterial trunk that was truncated. It was a fortunate solution. I was so happy for me and for the young lady anyway.
For the patient, absolutely, absolutely. My question to you is, do you see that with these autonomously functioning thyroid nodules, that they tend to be slightly more hypervascular, and should we be more concerned about these nodules when it comes to ablation, as opposed to some of the more cold nodules?
Well, it's a good question. This is the first complication of bleeding, so important case that I had in my experience. But I think this is not related to the high vascularity of the autonomous functioning thyroid nodules, because we can control it during the procedure, but was completely related to the superficiality of the arterial trunk that was very, very very superficial, subcapsular. So it was easy to truncate it. Probably, I think that a good probability that the arteria was truncated during the ablation. So she opened completely, and the proximal trunk bleed during after the ablation. So I think that in this case is an anatomical situation that was able to produce the complication. So please check to the anatomical position of the vessel, of the main vessel, not only in the thyroid gland, you know, but also during the procedure when you perform the ablation, to see if there are large veins in the soft tissue during the trajectory of the needle that you can cross, and so you can have hematoma. So I think that is a great part of the procedure to check by vascularity, to check the vascularity with power Doppler examination of all the veins and arteries of the region that you are treating.
Thank you. Dr. Park, do you have any just quick comments?
Yeah, I like to have
the
my
next case,
recent, you know, the bad experience, and then I was not experiencing like Dr. Spiezia, and then the patient all the huge the left side goiter, and then it's already, you know, compromised you know, trachea, the ship to the right side, and then at the end of procedure, I did the multiple accesses because it's too large, you know, from the top to the bottom, and then three times at the least, and then at the end of procedure, when I pulled out the needle, the patient, you know, kind of complained of choking, and then I did a physical exam. It's really tense, and unluckily, in that case, patient was really with a high anxiety. I should just call the ENT, you know, team, and then we should intubate, and then we can clean out the blood clots. And I was luckily in the OR, and then I asked them what happened. Is there's no serious arterial bleeding, but there was a hematoma around the entire, you know, the thyroid nodular capsule. So what I thought was, you know, the hydrodissection is good to, you know, control the pain, and then also, you know, kind of insulate the heat, you know, to the transmitted to the strap muscle adjacent structure. But it was a venous bleeding. I think that because of large size nodule, vein was engorged, and then luckily with the multiple accesses, I think a big vein on the surface, you know, during my access, you know, pass was injured after pulling the needle out. Because of hydrodissection, bleeding, you know, it could not stop. So hydrodissection provide, you know, kind of some space, you know, let the bleeding continuously. Retrospective, I think that if I didn't use a hydrodissection, you know, all the potential that, you know, preauricular fascia might be helped, you know, in controlling bleeding. But because of hydrodissection, even it was a venous bleeding, it stopped when the hydrodissection, you know, space was completely filled. So in thyroid ablation, I thought that life-threatening situation will be vasovagal reaction, sometimes, you know, cardiovascular compromise and lidocaine toxicity. But I think the bleeding is really, I think, serious, you know, situation if you cannot control. So, but congratulations, Dr. Spiezia. But my case was, even was a bleeding case, I really had a hard time. Yeah, but patient recovered nicely.
These are extremely, extremely valuable points. I mean, you know, I think we, you know, once you start doing this, and for those who have done this and been in this situation, it could be scary. But I think, you know, I think these are important points to realize. You know, these bleeding situations can occur. Arterial obviously more concerning than venous, but something you definitely have to be aware of and be on the lookout for. Real quickly, I just want to introduce, I mean, I introduced Dr. Spiezia before, but just Dr. Park, for those of you that don't know Dr. Park, well, I think everybody knows Dr. Park, but for those that don't know Dr. Park, he is the Associate Professor in the Division of Vascular and Interventional Radiology in the Department of Radiology at the University of Virginia. He did his training in residency and interventional radiology fellowship at the Yongbuk National University in South Korea, and then an additional vascular and interventional radiology fellowship at the University of Michigan. He's been on the faculty at University of Virginia for I think over a decade now.
Yes.
Over a decade. He's really one of the first individuals in North America to really do radiofrequency ablation for thyroid nodules. So it's really a true honor and pleasure to have Dr. Park here. And Dr. Park also has a book on radiofrequency ablation. So a little pitch from him. He didn't ask me to make the pitch, but a little pitch for Dr.
Yeah,
Park.
thank you for your kind instruction. Thank you.
Absolutely. So we're going to move on to Dr. Abraham. Dr. Abraham is an endocrinologist at the University of Utah since 1998. His practice is entirely dedicated to taking care of patients with thyroid and parathyroid tumors. He's taught several U.S. courses for ACE and ATA over the years. He's passionate about performing point of contact thyroid ultrasound imaging and conducting cost-effective percutaneous interventions for his patients. So I'm going to let Dr. Abraham take over, but I'm really happy we have a surgeon, an endocrinologist, and a radiologist on this panel. So this is truly multidisciplinary. So Dr. Abraham, it's all yours. I think you're muted.
Thank you for the kind introduction. And I'm humbled by my inclusion in this esteemed group of colleagues. I have nothing to disclose. I have 6 cases prepared. I'll try to go through them quickly, and we can discuss as we go along if there is something that I'm less clear about, or we can save the discussions to the end. First case is a 56-year-old male who presented with a large mass in the neck for 3 months duration. Before I saw him, volume was 21 ml. It was aspirated once. And these are studies as I conducted. He had a sizable mass that was anteriorly palpable with mural debris versus, it does not look like a solid tissue mass. To me, it felt a little bit more like leftover clot after the prior aspiration. So this case illustrates some of the difficulties with regards to the thickness of the consistency of the aspirate. The only 2 times where you can predict the fluidity of the content is if there is floating debris or if there is a fluid line after an aspiration few weeks or months ago. That is separation of blood products. In this subject's case, I had to use an 18-gauge cannula and needle to aspirate. And even then, it was very thick. And the main challenge, of course, is it takes a long time, sometimes as much as 12 to 15 minutes. And you can see various stages of aspiration going on here. The clot is partially excluding the needle here, and so it does here. Some of it comes in, and then it clogs. But in years past, I used to use saline wash, but I truly think perseverance is more important than saline washout. And here, you can see more clots clogging the needle. But if you persist with it, you can get it almost completely empty. It probably took 18 minutes or so. And it is very important towards the end of the procedure, when patients swallow, the needle might come out of the capsule. So that is very, very important to make sure you have the needle position in the cavity. And here you see the injection sequence occurring, at least a portion of it. And you can see it going like anteriorly. That's because this area is clogged and probably quite thick. You cannot control it, of course. And this is 6 months later. The nodule itself looks very different than from what we saw initially. The present volume is just under 2 cc. There is a isoechoic nodule, perhaps with a thick capsule, but it hasn't recurred. Usually, if it doesn't recur within the first couple of weeks, or usually by end of 3 weeks, if it doesn't recur, that's a good sign usually. It's unusual to gradually recur. When it bleeds and recurs, So that was a favorable outcome. So the take-home points, it can take a while. Use large gauge needle if you must. One thing I would like to stress is when you're using large bore needles, particularly if you feel you need to saline irrigate, you have to be very meticulous in aseptic precaution. Alcohol, of course, is sterile, but saline with skin contaminants can cause problems. Fortunately, I have not seen any aspiration-induced infection or abscess formation, but it is reported in the literature. So one has to be meticulous about asepsis. Moving on to case 2. Here we have a young lady, 20 years old, very thin neck. She noticed it for about 4 weeks. It's a soft cyst, but it's cosmetically disfiguring to her. And the volume was 15 mils when we started. Here is a very thin wall, uniformly cystic nodule, quite sizable. And here you see various aspiration sequence here. Again, soft tip catheter was used in order not to irritate the posterior capsule. And here you see near complete collapse of the cavity. And these completely collapsing cavities in thin wall cysts usually respond extremely well to alcohol injection. And here is alcohol injection happening. Here is some more. And this is, of course, I do vocal cord checks, as Dr. Spiezia also pointed out, in every patient before and after. And here is the post-injection image. And here we have the patient restudied 15 months later. It was delayed due to COVID. There was a structural change from 15 mils down to nothing. And you see a small speck of a cyst with the echogenic colloid. I truly think this is the cyst which has not recurred. I'm hoping this doesn't recur for her because she's very happy and surgery was avoided. And Dr. Spiezia also pointed out earlier on, it's a good thing a surgeon made that observation instead of an endocrinologist. Oftentimes surgery is forced upon our patients. And that's exactly what was offered to her initially. So take home point, completeness of aspiration is key before injection. Sometimes it's hard, it takes a long time depending on the thickness. It's important not to induce intracystic bleeding. And we'll see some examples in cases coming up. And they're very responsive, particularly the thin wall ones.
Can I just sorry, Dr. Abraham, can I very briefly interrupt just to ask you regarding the volumes of ethanol injected and the duration that you leave it in, and do you ever leave any ethanol in or do you aspirate it all out?
It's all coming up in the next few slides.
Oh, wonderful, wonderful.
The answer to your question is, I don't reaspirate ethanol. Number, it's unnecessary. Number 2, it reduces efficacy in some studies. Number 2, typically 30 to 50% of the aspirated volume is replaced with alcohol. In my humble observation, the more complete you're able to aspirate it, even 2 to 3 cc's is enough. The more, so the key thing is completeness of aspiration. So typically about 1/3 to 50% of the aspirated volume is replaced with alcohol. So case 3 is another young lady with a sizable mass of about 20 mils of a complex multiseptate cyst. And this is one of those situations where patients hear about alcohol injection and they are so convinced even before they see you, that is the option for them. Again, surgery was forced upon her and she wanted to pursue non-surgical intervention. And this is quite large and multiseptate. Sometimes these cysts are all interconnected. and they can aspirate. When you aspirate through one cavity, they all empty. Here, that didn't occur. I couldn't aspirate some areas of it. And after careful counseling, I did explain to her that the mural component, which had vascular flow, will be a problem. She wanted to pursue alcohol injection, so the mural component was targeted and injected. And you see a nodulogram, and that's vascular injection. In the interest of time, I didn't go through the Doppler sequence, but the injection occurred here, but you can see it light up everywhere, including here. And this is where the problem started. Can you see my pointer? And that's where the problem started here. She started bleeding into the cavity here. And you can see some pulsating vessels and blood dripping down. And it's very difficult to stop bleeding by direct pressure once it occurs in the intracavitary space. The best course of action is to allow natural tamponade to occur. And the fortunate thing is the thyroid capsule has a finite volume, and so does the nodule. So tamponade almost always occurs. And here you can see this vessel is pressed against and it stopped bleeding just spontaneously. Of course, you tell patients that if there is any change, she was observed for a good 2 hours before she was sent home. And there was not further worsening. And ice pack was applied. And I thought it wouldn't respond, but look at how well it responded. We started with nearly 30 mils. 6 months later, you have a more typical spongiform partially cystic nodule, which makes this nodule will need intervention at some point, perhaps by radiofrequency ablation, particularly the solid. There was much less vascularity inside the mural component after the vascular injection with ethanol. So this was purely handled the least expensive way that I know with alcohol ablation. She was offered radiofrequency ablation because we are also doing that. But in the interest of cost and favorable outcome after alcohol injection, she wants to wait. So that's where we are at. Few important pointers. Generally, I don't like to inject mural mass when the cavity is quite large because it usually leads to bleeding. And as I indicated, tamponade eventually occurs, but it can be a rough go when you're watching it to bleed continuously. The one thing I've learned is most often we used to think if there is bleeding, it leads to recurrence, but that's not what I've observed. Most nodules that have mural component that bled respond just as favorably as any other cyst in some situations. So I've been a little bit more optimistic, even if there is a little bleeding. This case number 4, is a very interesting, he's an ultrasound radiology equipment salesman. He saw this right lobe nodule years before he saw this on the left side. And it's very interesting. He himself came and said, I have this cyst, one is cyst, simple cyst, and he came with the diagnosis. And of course, you're interested in this nodule because this is almost taller than wide, heteroechoic, predominantly isoechoic with ill-defined margins, with peripheral and internal vascularity. Of course, it was biopsied and it came benign. This nodule was aspirated already 2 times elsewhere. And some important thing I wanted this case illustrated to me. You can see the distorted anatomy. You can see the striations of the esophagus here. And you can see the carotid artery displaced to the lateral aspect. And here you see the sympathetic trunk. So this is very important during alcohol and RFA. The anticipated anatomical correlates are displaced and distorted by the massiveness of some of these cysts and nodules. So you have to be very careful to identify these structures beforehand. So here we went through, of course, attempted aspiration. Again, it took a while and you can see some material going through. And this case illustrated another important finding also. Note the thick capsule. Thick capsule that forms after aspiration, usually indicates significant capsular vascularity. And these are often associated with high failure rates. And you can, even after near complete aspiration, you see the thick cavity wall. So we went on to inject alcohol. Some more alcohol was injected. I was a little on the side of 50% of the aspirated volume in his case because of the thick capsule. And this is after injection. There was no bleeding, which is usually a very fortunate thing. And this is 9 months later. This is the left lobe cyst, a remnant of the cyst. A small portion is left behind. The volume is about a cubic, less than 2 cubic mil. We started out with almost 50 mils, so dramatic response. Of course, the right lobe nodule, benign nodule, which is about 2 centimeters, is still stable. I'm going to skip case 5 and case 6 in the interest of time. Case 6 is worth noticing. Again, another complex cystic nodule with a little bit of bleeding already, with a angulated collection of blood. And of course, there is quite significant vascular mural mass. This is reminiscent of case 2. This patient underwent aspiration and biopsy, and it is benign. There is a good chance it will recur, but it hasn't recurred yet, at least by telephonic visits. We'll have to wait and see what happens. It's a benign nodule. So to recap, I compiled these 6 questions that I get asked. What size needle do you use? It depends on the contents. I usually start with 21 gauge cannula if there is a vascular mural mass or a vascular wall. If it is a simple cyst, if you feel you can confidently avoid the posterior capsule, you could use with a standard 21 gauge sharp needle. Parathyroid cysts usually are extremely thin liquid. Those have ablated even with 25 gauge needles. So it depends on the circumstance. How much alcohol to inject? Dr. Sinclair asked me about that already. 30 to 50%. The lesser the volume you can get away with, the more complete aspiration you conduct. Leaving the alcohol versus aspiration, reaspiration, I think it serves no purpose. Nobody gets alcohol toxicity. Even otherwise, we all pay top dollar for that experience anyway. So I've never seen alcohol toxicity, even with 10 cc of injection in exceptional cases. How to prevent leakage? This is a very important thing. A lot of times, the capsule is so thin and the cyst is so massive, it stretches everything to almost right underneath the skin. So it is very critical to induce a crack where you pull the skin. I'll show you a cartoon about that. And that serves as a sealant when you pull the needle out. Use the smallest gauge needle you can aspirate. And the third thing is trans-isthmic approach may reduce leak, but when the cyst is so large, there is usually no isthmus in these patients because these cysts cross the midline. So you'll have to be ingenious to come up with some system to stop leakage. You can use finger pressure also after withdrawing the needle for a good 5 to 10 minutes. Should I add lidocaine? Usually no, I think that dilutes alcohol. The interesting thing is if you inject it into solid nodule, it's painful. Also, but if you inject it into a capsule after it completely collapses, not under tension, it's completely painless procedure. Patients have no pain, even with relatively minimal perithyroidal anesthesia. Intracystic bleeding I already discussed. And this is the Z-track. So you pull the skin and subcutaneous tissue. You can be quite vigorous without hurting the patient. and inject, go on to the target, and then when you let go and pull the needle out, this is the track that forms. So you're basically puncturing at different levels of the facial and the muscular if you have to go through. Using a cannula is very helpful because you can detach the syringe and inject. It usually, you'll have to measure the amount of volume that it holds. So I add a little bit extra alcohol to it. It is also very important to keep track of the alcohol injected because you shouldn't exceed more than 50%, or at least there's no reason. So good sense of what is being injected should be monitored. That's all I have today. I'm very keen to hear from my colleagues and the attendees what they would have done differently, what I could have done differently also. Thank you.
Thank you.
Thank you
For this
Great
beautiful
presentation.
presentation.
So we do have a little bit of time left, even though we're coming close to we are at 7 o'clock right now. But the one question I think a couple of people asked is the cost of the alcohol right now and how to get it. I think it was recently given orphan drug status, and the cost has gone up by over 1,000%. So I think
Absolutely.
how do
So
we deal with that?
few solutions. One is to use laboratory grade or pharmaceutical grade alcohol. I mean, absolute alcohol is absolute alcohol. It's distilled, it's 95%. Nothing even survives when you have alcohol that's denatured and it's 95+% pure. So you could use laboratory grade or pharmaceutical grade USP alcohol, which comes in 500 to 100 ml containers, and it's very inexpensive. But I do disclose that to patients, that it's a less expensive alternative. Some institutions will refuse to allow you to inject pharmaceutical grade or laboratory grade alcohol, which is just as much or more, in my opinion, than even the ones that are used for intralesional or procedural interventions. The best approach is to involve your pharmacy. Sometimes they prefer to prepare and load it and send it with the patient's label to your office. So discuss with your pharmacy if they can prepare it under hood and send it. That's the easiest way around it that I've found.
Dr.
That's certainly how we've got around it too, is requesting from the pharmacy through the hospital. That's how we've managed to get around that cost issue. Just Dr. Park, just to address a question to you with regards to these complex nodules and thermal ablation versus ethanol ablation. Dr. Abraham, please weigh in, and Dr. Spiezia. What sort of percentage solid to cystic, when would you say, look, I think radiofrequency is going to be maybe a better option than ethanol, or do you think both options are as valid as each other for complex nodules? Just interested to hear the opinion from the panelists on that issue.
Yeah, I like to show you, but not right now. But I think our thyroid and others are like I like to say it's a continuum of between solid and a fluid, And then so it's complete solid, it's complete cystic, and we cut it half in between, half and half. So depending on according to the research, 20% conclusively. More than when solid component is over more than 20%, the efficacy of the ethanol ablation really drops. So definitely solid component, if you do not inject needle inside within the solid component, if you do not inject the ethanol, a solid component is out of control. So after treatment, really there's a solid component. It could be gradually, reduced. It will disappear. But the more solid component, it should be controlled more by the, thermal ablation. So really, there's a small amount of solid component rather than only, the ethanol ablation only for the cystic component, maybe staged, direct ethanol injection could control solid component. So I like to say it'll be between 10 to 50%, but more than 20% you should expect, or you can talk to the patient. The patient need repeat, the thermal ablation to control the solid component, or more of the control by the ethanol ablation. Yeah.
And combined ablations do at the same time. The
I think
combined,
the same time is too
played a bit
much.
with this, so
Yeah, it's cost-wise and effort-wise. If you really expect good result, at least it's better to be conservative, rather than try to do everything. Let's say there's a vascularity in the septum, right? It can cause bleeding, something like that. Ethanol is relatively, I think, it's mild and safe, procedure. Why don't you do it and wait at least several weeks, couple of months, and then we can judge, what is the next, rather than try to do everything. As you see, Dr. Abraham, he had great result, and so even there's a bleeding, it's going to be absolved and then gradually get better. So my just the personal policy is more of the staged procedure rather than doing everything at once. Yeah.
And I think, Dr. Park, you want to mention real quickly, you had an option for something other than ethanol?
Yeah, polydocanol. Actually, polydocanol is one of the scourging agent, using in interventional radiology for the cystic, so like a lymphatic, the malformation, something like that, is a scourging agent. So as I know, the polydocanol, the usage was reported in some Latin America, in China, and other countries. And Dr. Beck, Jong-Han Beck in Korea, recently he published polydocanol versus, ethanol. Definitely ethanol has a more efficacy, but polydocanol is not a bad, option. It really, the ethanol is not available. So I also use the industrial ethanol for the large, huge, like a 500 milliliters, liver cyst, kidney cyst. Before the industrial ethanol, I didn't have any single, bad, kind of complications or experience, but it's more of the kind of legal or, policy issues. So yeah, it's better to follow Dr. Abrams, let the palmers get involved in the between, and then you can put a safe wall or barrier, and then I think, I think no problem with the for efficacy with the industrial ethanol at all. Yeah.
All right, well, I think, we have a couple more questions, but I think in the interest of time, we may have to come to a close. Catherine?
I think that we probably do need to come to a close. Unfortunately, I think these are topics that we could speak about for much longer. And I would encourage anyone who has questions to either email the panelists directly or to send an email to via the NASIT website, and we will address those questions and field them to the appropriate people. The website address for the society is www.nasit.org. There is an inquiry button on the website for membership inquiries and also for questions.
And once again, thank you very much to all the panelists. This was a great discussion. Like I said, we can keep talking about this for another hour easily. So, but this was excellent. I learned a lot, and I'm sure everybody else did as well.
Thank you all so much. It was fantastic.
So much, everyone. Yeah, have a great evening.
Thank you.
Thank you.
Thank you.
Thank you. Thank you so much.